Now I'll introduce our guest speaker for today, Dr. Margarita Elsa Villarino, who is a physician, epidemiologist, and researcher with more than 30 years of professional experience in clinical trials for new tuberculosis medicines and in the epidemiology, outbreak investigations, prevention, and control of infectious diseases. And Dr. Villarino worked as a medical epidemiologist from 1988 to 2019 at the US CDC. And for the last 6 years of her CDC career, she was CDC Mexico office director and the public health attaché for the Department of Health and Human Services. She has also served as physician consultant caring for patients with TB and MDR-TB in the public health tuberculosis clinics of DeKalb County and Georgia and Santa Clara County here in California. And since 2021, she has been a medical epidemiologist at the California Department of Public Health as well. Lastly, she has also joined UCSD's Global Health Program faculty in the fall of 2022, along with a lot of other things that she has accomplished throughout her career. But I'll hand it over to her now to speak more to that and share her presentation. So thank you so much for joining us.
Thank you, Lucia. I'm going to thank you for the abbreviated presentation, and thank you so much for the time for the public listening. I hope that this, please tell me when I have the correct.
We still see, oh, there we go, perfect.
Okay. So my public health journey begins in Tijuana and with my parents. My father was the ultimate caregiver. He was the provider for his household since he was 10 years old and had only a third grade education. And this picture here shows him and my young mom with another couple, Dr. Stuart Smith and his wife, in a Tijuana restaurant. These two couples became friends after they met in 1947 when my mom was 16 and needed an obstetrician. Our families lived a true cross-border friendship. The Smiths lived in La Jolla, California, and my family in Tijuana. That was strengthened by the ways they helped each other. Dr. Smith safely delivered my siblings and me into the world in San Diego hospitals. And my dad went flying with him to the more remote areas of Baja California to be medical interpreter for Dr. Smith, who was a fleeing Samaritan. Through their sacrifice, my mother and father ensured that we children had the privileges associated of being a US citizen from birth. And for this and many other reasons, my parents are my first heroes. When I was about 10 years old, I read this book by Paul DeCreux, The Microbe Hunters, and I fell in love with infectious diseases. Perhaps this was because I also, in addition to loving reading, I loved solving questions. And this book taught me that to cure infectious diseases, doctors must first learn what is causing them, how to identify and know what is the pathogen that is causing the infectious diseases. So in my dreams and after reading this book, I wanted to one day learn about hunting these microbes. So really, writers of books and novels and biographies and journal articles have always also been heroes of mine. These are my alma maters. I started school when I was 4 at this Colegio La Paz. You see a picture there. It's a very good school in Tijuana, Mexico, with high academic standards. And it was also something that my parents sacrificed household income to be able to have me go there. And my brothers also attended this school. So I graduated when I was 18 years old, and then the year prior to that, my father had passed away. So his dream of me coming to university in the United States was not possible anymore because of financial reasons. But I was still very privileged because I could choose what I wanted to study and where I wanted to study as if I could afford it. So I went to the Universidad Autónoma de Baja California. Sorry, when I go from English to Spanish, sometimes my tongue gets twisted. Universidad Autónoma de Baja California Medical School in Tijuana. And there I studied medicine for the next 6 years. I graduated in 1986 with a general physician's title. At this time, my dream had always been to continue my medical education, doing a residency and a fellowship in infectious diseases. But for this, it would have meant that I would have had to move away from Tijuana. I would have had to live with a very small salary and a lot of work. And also, I had by then a 3-year-old daughter that I needed to support happily. But it meant also that I had to make another choice. And that's how I arrived to the San Diego State University Graduate School of Public Health. So I chose public health in graduate school because it was a convenient thing to do, really. I knew very little about public health. I had to pass the TOEFL exam, the GRE exam. I hadn't, in the last 6 years, studied anything even closely related to math and biostatistics, but I had to pass a placement test to be able to take graduate level biostatistic classes. But I've always been kind of a book nerd and study nerd, so I could get, I was accepted and could get into this program. Then I had to choose what concentration I wanted to do. And reading through the book catalog, I saw epidemiology and biostatistics as a choice. I knew very little about this, but they sounded interesting to me, or more interesting than the other choices available. So I started down this path. So at SDSU, and for the first time, I encountered what some of you would recognize as barriers to education, because I had first a language barrier. My English is not my maternal language. I had a transportation barrier because I had no car and had to go to school every day from Tijuana to San Diego. And I also even encountered some stereotyping barriers because even though I had always been a very good student, one of my professors at that school, and he was well-intentioned when he said this, but still felt a little bit biased to me, said that the Hispanic students in his biostatistics class usually did not do well. On the other hand, at San Diego State, I found wonderful opportunities that were not available to me in Mexico. I could get a student loan, so I could actually study and not have to work except for a few hours. I could get childcare for my 3-year-old daughter that went to school with me every day. And when she got asked, where did you go to school? She probably said, San Diego State University. She learned English in about a week and was very happy there at the childcare center. I had wonderful schoolmates and professors, and after 2 years of studying, I graduated against the stereotype, maybe, because I had the highest grade point average in my generation, 1988, San Diego State University. Then, excuse me, I need to figure out a different way to, there I go. So I had many wonderful mentors and people that inspired me into the world of public health. during the time I was in school, but I only have time to mention this one. And this really was the most significant. His name was Dr. Abraham Benenson. He was a retired US military doctor, Army doctor, who was already extremely well known and famous for having worked in very important diseases like cholera and polio, and in having helped develop vaccines. And he was a true scholar, gentleman, and professor. But after he retired from the military and after holding other professions in medical education, he came to be a professor at San Diego State, and he was my infectious disease epidemiology professor. And we used this book called Control of Communicable Diseases in Man. He was the editor of that book, published by the American Association for Public Health for many years. And this is kind of the textbook, handbook. And if during that time we had our cell phone where we could consult everything quickly, at that time we had this little pocketbook that fit into the pocket of your white coat, and you would pull it out to find out everything there was to know about the infectious disease that you might be encountering in your clinical practice. Also, the epidemiology, the distribution in the world, the risk factors. And Dr. Benenson was sometimes when he would teach classes, he would say things like, and here's a picture of us during the cholera pandemic in this part of the world and what we did to help establish what are the guidelines for treatment with rehydration and others. So it was like an amazing history course at the same time as an epidemiologic and an infectious diseases course. So forever grateful to Dr. Benenson. He really truly was the one that said to all of the students, if you wanted to be an infectious disease epidemiologist, you should go to the pinnacle of infectious diseases studies, which is the CDC. So at the time, I knew of the CDC, because what person doesn't if they're in medicine, but I did not, I see a thing on my screen here. I did not know about.
Oh yeah, there's just a poll that pops up in the middle of the meeting.
Okay, I did not know about the EIS program, but the Epidemic Intelligence Service is a training program at the CDC, both because of Dr. Benenson's encouragement and because, amazingly, at that time, some recruiters or people from CDC had come to my little classroom. And when I say little, San Diego State University Graduate School of Public Health was really in its beginnings. But the CDC came and told us that if you had the right background, and by that you had to be a physician or a PhD, or maybe a nurse with a master's degree, you could apply to the Epidemiologic Intelligence Service and become an EIS officer. EIS officers, about half of the ones accepted every year into the program, work at the CDC in Atlanta in different assignments, and the other half go to big state, local health departments, where they perform the duties of public health officers and epidemiologists. So it's a really interesting, it's not a degreed academic program, but it's a very prestigious academic program in the sense that it puts you in touch with your colleagues in the previous generations of EIS officers, and it's really something that cannot, I agree with Dr. Benenson, cannot be rivaled if you want to learn about infectious diseases, epidemiology, and public health. So I was assigned to the nosocomial infections program. My mentor was Dr. Bill William Jarvis, like the second author in those guidelines that I show there for illustration purposes of what is the type of work that the CDC does, writes guidelines, performs surveillance, does outbreak investigations, and how when you're an EIS officer, you get to do a little bit of all of those things under very good mentors and people that really want you to succeed and take over their place in the history of the work of the CDC. I also wanted to work as a clinician, and I had to then take my USMLE boards in Georgia to be able to work. At the CDC Atlanta at the time, to work as a physician epidemiologist, it didn't matter where, at the time when I was a trainee, I could just have passed my ECFMG exam and did not need to be boarded as a foreign medical graduate. I did need to be a US citizen because of federal employment, and again, because of my father's foresight, I had that. But if I wanted to stay employed at the CDC after training and then also work as a physician, I needed to pass my board exams, complete a residency in preventive medicine, in my case, and get boarded to work. So that's how I could also volunteer to work in the DeKalb County Public Health Program, the TB control clinic. And this was very interesting to me because coming from always having worked in Mexico under very difficult conditions in a public hospital, I found that in Atlanta, where I was now living in the first world, there were racial inequities and disparities in access to healthcare for the TB patients in Atlanta that sometimes were even more significant than the ones I had faced in Mexico. So it's a big learning that you do when you move anywhere. I ask or answer when people say, where did you grow up? Often question when they know you're Mexican, but you live in the US, but who knows who you are? Well, I say, well, I grew up in Tijuana. I lived there till I was 27 years old, and then I grew up in Atlanta because I worked there for the CDC for 31 years, and living and working is learning. And I raised my children there. I was a professional there. I made my friends and family there, and still consider Atlanta one of my homes. Let's see, for some reason. So during the time I was an AIS officer, and in here in this slide, you can see a timeline of significant investigations in public health and moments in public health that have involved EIS officers throughout the time. EIS program was founded in 1951. I was an EIS officer from 1988 to 1990, and then a resident in 1991. And during that time, and with some colleagues, we did what EIS officers do, which is to be disease detectives. And we went to investigate suspected transmission, nosocomial transmission of tuberculosis in a hospital unit for HIV-infected patients in San Juan, Puerto Rico. So Sam Dooley, listed here as first author in this report that we published after the investigation, and others did this work and could define the routes of transmission, the risk factors for transmission. Nosocomial transmission of something like tuberculosis is not a commonplace finding. it wasn't even then a commonplace finding, because the infection control that is done in hospitals in the US, where if you go into the hospital with an infectious disease, you get put in isolation, and all the safeguards to prevent transmission to other patients that might be there, or to the healthcare workers that might be taking care of you, are put into place. But at that time, and with the HIV epidemic reigniting the cases of tuberculosis all over the United States, but especially in big centers, big cities such as New York, and places like Miami in Florida, and San Juan, Puerto Rico, with its connection with the United States, there wasn't an understanding that the opportunistic infections for the very immunosuppressed HIV-infected patients not only included the ones that are not transmissible or communicable, like pneumocystis carinii or toxoplasmosis, but also the commonplace infections like tuberculosis that basically if you don't have an immune system to help you fight them off, could become very severe and even cause have a great proportion of mortality. So we published I was just going to show you during the years I was an EIS officer. I worked at the National Center for Infectious Diseases, it was called then. Right now it's called the National Center for Emerging and Zoonotic Infectious Diseases at the CDC. This is the most current org chart. I then moved to working in the National Center for HIV, STDs, and tuberculosis prevention, first as a preventive medicine residency in STDs, and then as a clinical researcher in the TB, in the division of TB elimination. Viral hepatitis didn't used to be a part of this national center, but now is. And I also had another very happy occasion during this time of being a preventive medicine resident and working as my first job at CDC. So I had my son, who's an Atlanta native, and that was quite a surprise, because it also meant that I had an opportunity to stay and work in Atlanta instead of coming back to California or to Mexico. I decided to make CDC my home and my career. This was in large part because of the great experience I had in training, and because my training years coincided with the resurgence of tuberculosis in 1985 in the US, and that peaked around 1992, about the time when I finished training and stayed to work at my first CDC job. The CDC had allocated emergency funding by Congress during that time because the US was in crisis. There was something needed to be done to get TB control back into its track. TB at that time also has started becoming a significant problem, because when it coexists with tuberculosis, with HIV infection, and because of the strains of tuberculosis that were resistant to the anti-TB medicines available at the time, it caused high morbidity and high mortality amongst the TB patients. So the CDC used some of the funding that was mostly meant, as public health funds usually do, for the control of a disease. They used some of the funding for research, and they started an intramural clinical research program for tuberculosis at the CDC. And how they sometimes say that moments in your career are sometimes being in the right place at the right time. This offered me the opportunity to be the researcher in this newly founded research group. So at the CDC, I was the team lead for the Tuberculosis Trials Consortium. We had clinical sites for enrollment of patients into the clinical trials that tested the new medicines for tuberculosis. They were first all over North America, mostly in the US and some in Canada. But then since from about 2013 onwards, we also had clinical sites all over the world, including in Spain, in Asia, in Africa, and because that's where the TB patients are. The US got its TB epidemic under control, but as you know, TB is a disease of poverty, social inequity disease, where the places in the world that also have the highest concentration of poverty and other social determinants of health also have tuberculosis. So the clinical trials that we conducted had to be performed not only for a US audience and population, but also for application into the places that needed most. So we did, I was part of many clinical trials. Clinical trials are very long in duration. And when I say many, I say 4 in the course of the 20 years I spent in this program. But this was kind of the last one that I worked with directly, and the one that I am choosing to highlight here because of its application for the US. So this is a clinical trial. We called it TBTC Study 26. It enrolled over 8,000 patients in 2 study arms. We compared the standard treatment for tuberculosis, which is 9 months of daily taking of isoniazid, a medicine that you use to treat and also to prevent tuberculosis, against a new regimen, which was taken only once a week. It was a combination of 2 medicines, isoniazid again, and rifampicin. And the trial was one, it's called non-inferiority, meaning that the new treatment regimen cannot be less effective than the one existing. As part of learning about clinical trials, you will learn that in modern times, if there's an existing treatment for any disease, then you cannot do through comparisons or placebo arm versus a treatment, because you cannot fail to offer an existing treatment to a population that you're studying. So you have to only do a comparative trial against an existing or multiple existing other treatments. And what you're trying to test is whether the newest treatment is effective or as effective as the existing treatment, but also it could be, for example, more cost effective and easier to implement and easier to finish for the patients, 9 months versus 12 weeks, affordable and applicable for populations. So in our case, we also found that the new treatment regimen was all of those things. And we had the good events that to be able to be published both in the New England Journal of Medicine as the report of the scientific results of the clinical trial, but in the MMWR, the CDC publication, where the recommendations and guidelines for treatment for the US are published. So in the same month and year, December of 2011, these 2 publications came out, and we could turn public health from an academic exercise of a clinical trial into a public health intervention, which is the use of this regimen for the prevention of tuberculosis. After that, I was ready for a new experience, and I'm going to say here that when I went to the CDC, because going to the Southeast US and living a life that was so different than what I knew before then, I felt that that was my international assignment, or that I had gone to work someplace else. Arriving in Atlanta, I felt like a recent immigrant to the US, even though I had a US citizenship. But then 20 years went by, and from the CDC, I got an opportunity to do an assignment in Mexico. And so I went to be the director of the first office opened in Mexico, was in Mexico City, from the CDC, Atlanta. And my job was to be the liaison between the CDC's infectious diseases program and Mexico's public health infectious diseases program, including the laboratory of reference in Mexico is called INDRE. At the CDC, in the US, the CDC is the national reference laboratory for our country. And epidemiology programs like in Mexico, the DGE, or General Directorate for Epidemiology, is the equivalent to our CDC, US CDC agency. So in Mexico, I felt like, people, border inhabitants like me in Mexico, when we go to the other side, we say, I'm going, voy pa'l otro lado, no? Al otro lado meaning the other side. So you live between the two sides, and to me, it was Mexico first, and then the US, and now I'm back on the Mexican side. And I could work for my US agency. I could synergize a multitude of resources that the CDC had, but I also had to learn what is called health diplomacy, global health, how to extrapolate the very ambitious agenda, how to push forward the very ambitious agenda that the CDC had for this international work in Mexico, with my Mexican background and way of being, and the Mexican style of very mannered ways. And you have to be very diplomatic and more gentle in your manners than what I had come to be used to as part of being US public health worker. So I love the challenge, and I didn't spend one day not being so tremendously grateful for this opportunity. I traveled all over Mexico. We did interventions in many different places, not just the border, as far away as the Yucatan, or as nearby as Cuernavaca, right next to Mexico City. I met wonderful researchers from universities and public health. I found a home again for 6 years, and I didn't want to leave, but my assignment finished in 6 years. So I came back to Atlanta to retire from the CDC. When you're a federal employee, you cannot retire when you're assigned overseas. You have to come back to your headquarters. It's important in the sense that you're at the beginning of your career, and I'm at the end of my career. So things about who and where are you going to be retired will become of relevance to you at some point. I was ready to retire, to move back from Atlanta to California, but not ready to stop working. So I started job searching. I was 58 years old. I knew I could keep my job in Atlanta as long as I wanted, but I already had 31 years of service and the age when you can retire. And so I decided to take the opportunity and the challenge, even though it meant job searching when I had really never done this before. I went to work at the CDC, when I finished my training, it almost like I did have to interview, but I didn't, I knew I was gonna be asked to stay if I wanted to. And here it was truly, I knew I had this great experience and a great career, but in California, I didn't know anyone to start off with. So it's a lot about where you are and when you are. But the Santa Clara County TV Public Health Department did offer me a position to work as the TV controller within the Santa Clara County. And even though this public health agency is 500 miles away about from my home in Southern California, and that I had to, again, take state exam boards for getting a medical license in California, I was able to do that and joined this program in the fall of 2019. And it's a very bad picture there, but my team is about 30 people in Santa Clara County TV program. Right there in the middle of those pictures, I arrived to learn about Northern California, the new ethnic groups that I had never really worked with, and both my staff and the patients that we treated represented, like people from India and China and Vietnam and the Philippines. They were a wonderful group, both patients and staff. It was a very large program. It is a very large program. But then in 2020, I got mobilized, as health officers often do, to work in the Santa Clara County response for COVID-19. So this meant, yet again, reinventing myself and using my skills again. I had thought I had gone to the TV program and be able to do this job with my eyes closed. Of course, always learning more things, but mostly being the one that knew more about what I was doing than the others. But then the field got leveled for everyone because we had a new infectious disease called COVID-19. I had to apply all my previous learnings because Santa Clara County asked me to be now in charge of learning about the spread of this virus in healthcare settings. So I went back to my original origins of being a nosocomial infection, healthcare associated infections officer. We partnered. Public health departments are not very well known or do not often do functions of research and investigations of this kind, like this genomic investigation, genomic epidemiology investigations that we did with UCSF and a center called BioHub at UCSF as well. But it was new grounds for everyone. And my background as a researcher and now a public health worker allowed me to contribute to learning what we needed to learn in terms of prevention in public health. That's your main goal, to prevent transmission for others and to control an epidemic by using my background skills and in a very large population. Almost 2 million people live in Santa Clara County, and I had very good teamwork that was able to describe the epidemic for Santa Clara County and also describe the spread of this virus in healthcare settings, such as congregate facilities, or otherwise known as nursing homes or long-term care facilities, where the spread of COVID, has many very specific characteristics that you might already have heard about or know. During this epidemic, we learned about that. And then I also was part of an investigation of COVID transmission in a very large emergency room of a very, again, large medical center in San Jose, California. And it was during this investigation that I met Dr. Erin Epson, one of the co-authors of this paper. The CDC also came to help with this investigation in San Jose. So EIS officers, like the first author in this paper, came to work in situ. I was the county health officer, and then the state of California came because it was an unusual event of having a very large outbreak happen in an emergency room. This report is published here, but it meant that I got in contact, my life cross paths with Dr. Epson, who's here pictured here next to me. She's the chief of the Healthcare Associated Infections program at the California Department of Public Health, where I work now. And she also allowed my coming back home to Southern California, because positions at that time in this program, which is based in Richmond, California, close to Oakland and close to Berkeley, could be remote from home because of the COVID-19 pandemic again. So I have worked there since September of 2021. I do medical epidemiologist functions, but I'm also very proudly the coordinator, or I'm in charge of reestablishing our program's work with Baja California's program, and we focus on multi-drug resistant organisms or antibiotic resistant organisms that cause healthcare associated infections. They're very impactful form of this type of infections. I collaborate with societies of infectious diseases nationwide and statewide. And but I also found this work for the first time remote and virtual, a little bit isolating and disconnecting. I guess I didn't grow up in the era of the computer and the work and the virtual work. So I was extremely happy to join when they invited me to be faculty at the Global Health Program of UCSD San Diego, where I work as a very part-time lecturer. I teach one class every quarter. It's a symposium format, 3 hours on the afternoons of Thursdays. I incorporate all of my professional experiences, all of my loves and mission in public health, infectious diseases, preventive medicine, into the training of and education of my students. I know that you out there are at the beginning of your educational path in medicine, and some days you will have accomplishments that are surpassed your teachers, and I will be very happy and proud to learn about those. I also wanted to say that if you ask me for a choice of professional specialty, I would not hesitate to say that if your heart is in it, choose public health. You can be a public health epidemiologist, you can be an infectious disease doctor, you can be a clinical trial scientist, researcher, and you will never have a boring day. And your mission to promote the health of others, to protect the health of others in the US and globally, will never, you won't have to do anything else besides your daily work, and you will find the satisfaction in that mission. So this is my story and my professional path. And I invite your questions if we still have time. It was long, I know. It has to do with me being the age that I am and the years that I have worked that I needed to share with you. Thank you.
Thank you. One question is, what inspired you to pursue an MD PhD versus only an MPH?
So I don't have a PhD. I have an MD, MPH.
Yeah, and
But
that's what the MD MPH, that's what they ask.
Yeah, that's a very good, that's a good question, because some of my students that I have now at UCSD are hoping to do MD PhD, and it has several benefits for students in the US, including that you could get funding, you could get paid sometimes for medical school and the PhD work. I have a good colleague that did that from Mount Sinai and NIH in New York and Maryland, even at my time, and it still exists now. I would not have been accepted. I already had medical school, and I did not want to repeat medical school in the US. So I did not want, that wasn't the path for me to go down. When I started my MPH, I did have the question, and other students that I have mentored, like MPH students for Emory that were my work students during the time I worked at CDC, sometimes would come to me and say, I finished my MPH, and now should I go to a PhD epidemiology program? Or some of them wanted to go to medical school. I remember very much a young woman that was from California and had already her MCATs, but had not had a good score, and decided to do MPH epidemiology instead, or maybe not go down the medical school path. But when she finished MPH and she asked me, she had the opportunity to be a PhD student at Emory. Again, I said, go back. She had an opportunity from UC Davis to retake her MCATs and get a better score. And if she did that, get accepted directly into UC Davis Medical School. So she did that, and she's one of many students that I have known as they're going down the path, like you, of medical school. And whether you do an MPH, a PhD, or a non-degree program like the EIS program, or a fellowship like infectious diseases, you can do all of those things by practice, like I did. I'm a practical infectious disease doctor, or by title, and some more now than you need the degree. Sometimes you need the paper, but sometimes, at least during my time, your professional experience is also what counts, and counts the most, really, for you.
Thank you. I have a couple more questions. One of them is like, is it easy to like choose a specific area within the infectious disease department? For example, say I want to specifically focus on, say, HIV or hepatitis B and C, or Is it
Easy?
possible? Because, yeah.
Yes, I don't know if I would describe it as easy, but I would say for me, it was a combination of choices, because I was always interested in tuberculosis, and I don't know how many of you know, but Baja California within Mexico is an endemic zone for tuberculosis. Tuberculosis is a medium prevalence disease in Mexico. It's not a high burden disease in Mexico like it might be in some places of Asia, Africa. In Latin America is like places like Mexico are medium incidence countries, but the border region, for many aspects, is the highest incidence for Mexico. So I saw a lot of patients when I was an intern and working in a hospital in Tijuana, and I was very interested in the disease. But when I went to EIS, you do a matching program, and you end up working in a program depending on had they chosen you to work there. TB program at that time was so small at the CDC that I felt I wanted an opportunity to go to something bigger. And I also liked STDs. So you have to fill out this paper and put like your three or four top choices that you would be happy. The philosophy of the EIS program is, if you're going to learn epidemiology, you can learn it whether you are working in infectious diseases, chronic diseases, or, hepatitis versus nosocomial infections. The training in epidemiology, not in the disease itself. So I said, okay, well, I really like infectious diseases. I don't want to go to other centers, but I'll go if they assign me there. But in my top choices, I put STDs, and then I put tuberculosis, I think STDs, and then because they required a third choice, I put nosocomial infections. I knew nothing about nosocomial infections, except that I had interviewed with them during the matching process, and they seemed nice. So I matched with them, and it was really, I couldn't have asked for anything better. It was great. The mentor was great. The opportunities for work were great. It was less snobby than other people in the Center for Infectious Diseases, where many people already had fellowships in infectious diseases. My program was really great. You sometimes choose because, nosocomial infections, I was assigned, but I really like the people that dedicate themselves to that, because they're usually a special type of people. Sometimes is, what you like in the lab. Sometimes is your best experience as a student. Sometimes you have a personal story with a disease and you want to, learn how to cure. HIV/AIDS was that disease for many people. Many people became infectious diseases doctors because of HIV/AIDS when it was no longer that popular in the US. So it's not easy, but keep your heart open and think of what really fits you, and what can you also offer. I feel like I never wanted to be a surgeon because I knew I would be a bad surgeon. I knew my strengths as well as I knew my limitations.
Yeah.
So while I admire that career, I would not have chosen it for myself. Within infectious diseases, I like them all. I like the viruses and the fungus and all of the infectious diseases.
Yeah, thank you for the amazing presentation insights. So there are a couple of more questions. And so based on your past medical experiences and exposure to various infectious diseases, which public health issue do you think remains unfunded and requires more advocacy than ever?
Many. And the answer is too long. And I think it depends in the area where I work, like within a very specific area, like nosocomial infections, we're focusing on the highly drug resistant, the ones that are resistant to a type of antibiotics called carbapenems, because they have the most mortality. Sometimes you choose based on the public health impact. How many people? Are there millions of cases or thousands of cases? Sometimes you focus on, is it a disease that has a high fatality? And and all of them are underfunded at a particular time. And also we live in this curious times that funding gets appropriated when there's an emergency, but rarely gets appropriated for long-term preventive type public health programs. Why couldn't we prevent obesity in children so that we attack diabetes as a public health issue in the US? Diabetics have risk for infectious diseases too. It's one of everything is connected. You just need to advocate for what you care for most.
Because our politicians are reactive. They don't like to talk about climate change, but then when there's a natural disaster, they get all worked up over it. And I think that the problem is that public health is the same thing. I mean, we've had some pretty good public health things that we've done in the past, like smoking cessation and other stuff, but that's because they were forced to do it. It wasn't so much like, so, and I think like as we're in an election season, you have the power to shape what things are addressed. Believe it or not, as a voter and as a young person, you have a lot of power. That's just my spiel.
Yes.
Okay, so another question. How did you find a position to work at the CA Department of Public Health? So this person is currently working in his or her MPH program and have trouble thinking of where to apply. So
I always tell my students, there's actually an internship. I have an intern right now from UC Irvine. So whenever you can, and during the time you're still in school, see if there are internship programs. There are CDPH internship programs for undergraduates and for graduate students. A lot of them used to be from schools in the Bay Area, but now, again, with the remote work, they accept students from all schools that fit. They open as paid positions. People sometimes do it when they're like juniors and seniors in undergraduate or doing their graduate work. It lasts usually around the same time as your school quarter lasts. And even though you could get assigned from many different positions, just getting your foot in the doors gets you farther along, because submitting an application to a big program like CDPH can get lost. Even fellows of mine that are CSDE is another way to get to that. For example, you finish your MPH work and then you apply to be a fellow in the CSDE program, is a state and territorial epidemiologist program. If you get this funding, you can then go and work in different agencies and institutions. And perhaps when you finish that fellowship, and that fellowship is paid by the CSDE, but people in CDPH, for example, would know you and would know of the work you do and how good you are and how flexible you were when they ask you to be part of a team. doing whatever. Always be willing to do whatever. Feel, do public service announcements, and even if it's remote from what your field you believe you studied. At the beginning, we all have to, not at the beginning, always. We always have to work with everything to get message out. It doesn't matter if you're the physician or the epidemiologist or the administrative worker. You have the same duty for public health.
Yeah,
Yeah.
I just put on 2 links. We actually had the person who's in charge of this program come and speak to us, the CDPH pathway internships and fellowships. The internship, they place you at a local public health office in California, and almost every county has them. I think like only 2 counties don't have them. They're merged with another one. So I put those there, and I think the application's due October 20th, and just apply. I mean, and they pay pretty well. I mean, they pay more than, minimum wage, which in California is quite a bit. But yeah, put those links there and apply to both of them and see which one. I think the fellowship you have to at least have 2 years of college, and they want 40 hours, and so that's, I think, mostly summer. But yeah, put those links on there and apply. I mean, I think that's, when you're starting out, apply, apply, apply.
I was extremely lucky. I mean, I say that humbly. I cannot even describe sitting in a classroom in at San Diego State campus and having, people come in person to talk to our class about the CDC and the EIS program. I can't even describe going to Atlanta, Georgia, in 1987 to interview, and how my Professor Benenson, had a good friend who at that time was the editor of the MMWR publication. And if you're a public health person, MMWR, you know what that is. Dr. Benenson told me, when you finish your interviews, because you go through interviews, they give you an assignment, and you go to different offices of the CDC. I had never been farther than California, than Nevada, in the US. So I went to Atlanta, and then the first person that interviewed me, his name was Robert Gunn, and he was a San Diego native. He had moved to Atlanta, and he gave me some tips. He said, as you go along your interview day, when they ask you why they want to become an EIS officer, I said, well, I gave my actual responses, just sounds really interesting. And he said, nah, you have to say, because this is like your life dream. You want to become an epidemiologist, a public health worker, that so-and-so who has come before you, and they're public health workers. I'm like, I know no one, except I did. There were 2, this is an interesting story. 2 people from San Diego State had gone to be EIS officer before me, and one of them actually became very famous in California because his name is Gilberto Chavez, and he was the state epidemiologist for California, recently retired for a great part of his professional career. And again, Gilberto had come from medical school in Michoacan, Mexico, to San Diego for MPH, and then ended up being the state epidemiologist for California. So our little school was a great place, and still is. So UCSD has a combined program now with SDSU, which has a PhD program for epidemiology. We didn't have that in San Diego. You had to go to UCLA or to Hopkins to do PhD work for public health at that time. Anyway, it's keep talking to people, work very hard, love what you do, don't get discouraged, and opportunities will come.
Yeah. One more question here. What was it like to go back to Mexico after having accomplished so much and be able to educate there and still learn more about health diplomacy? The person loved this presentation. Thank you very much.
Thank you. It was great. See, for multiple reasons, including, Tijuana is a small city with a lot of opportunities, but you always live frustrated also because of how many things we don't have. And one of the big problems, love living near the US, people in Tijuana, but hate all the things that are associated with the bad rap that one gets. So when I went back to work in Mexico, even though my main assignment was for the work of the border, the US-Mexico border, not just in California, but all throughout Arizona, New Mexico, all the border towns like Tijuana, San Diego are. But because of it being a federal assignment, I wasn't meant to go to Mexicali, the state capital of Baja California, rather. I went to Mexico City, and Mexico City, let me tell you, has nothing, there's nothing short of Mexico City to any big cities or cities that you might love in the US. It's vibrant, is historic, is full of contradictions. It was a place where I would have chosen to go be a resident and a fellow in internal medicine had I not been at a point in my life where going to graduate school just made more economic sense to me. I could not afford 6 more years of training when I finished medical school with a salary that is, contrary to what was mentioned to California salaries, is barely living wages. So when I went back to Mexico, I was, again, like when I went to Atlanta, I was a opportunity migrant, if you want. I chose to go there. I brought the resources to the work that I love to do. We had so many opportunities to work on interesting things, like when congenital Zika syndrome happened. How interesting that we could bring the latest PCR test that the CDC developed quickly, because I was there. I knew who at the CDC could get this resource down there. I could pick up the phone and speak to a person who I might personally know, or quickly could say, hey, I'm your colleague, I'm a CDC person, I work in Mexico, and I got an answer like, hey, I didn't know CDC had offices in Mexico. I'm like, yeah, we're a 2-person office in Mexico. So I did not, of course, of those of you that are listening, either because you are migrants yourself, the children of migrants, or because you're interested in global health and you know what it is to practice in places with such different resources. You know how difficult that is. But then you focus on, what can I do? What can I do about this? What can I offer to make the situation better? So I came as a privileged Mexican. Last story, the US government asked me to send back, I have a Mexican passport as well as a US passport. In Mexico, you can be a Mexican national. I'm not a Mexican citizen. I'm not allowed to vote. and I'm not, I don't have certain citizen privileges, but I am a Mexican national, being the daughter of two Mexicans. I have had that from the time I was born, a US passport and a Mexican passport. When I went to work as a US employee to Mexico, they didn't, it wouldn't have been an issue if I had a French passport or in addition to my US passport, but the fact that I have Mexican passport, they asked me to turn it in. I had to write a letter to the Department of State that said that I was surrendering my passport for the time I was there. And the reason behind this is because I went there to represent a US agency. I had a federal government salary. The US government is not interested in you becoming too friendly, too used to where you are, because your mission there is to advance the mission of your country. But for me, I went to Mexico. Had I gone to, like some other friends of mine went to Vietnam or some other countries, I would have not had this duality of feelings that I had. But also, I truly believe I wouldn't have been able to accomplish as much as I did, because health diplomacy is not something that you learn just because you speak Spanish or the language. You really have to live it. You really have to put yourself in the places where you work. And I can tell you that a lot of people that work in Mexico, my experience at the US Embassy is that a lot of employees came and went after spending 2 wonderful years there and didn't learn what it is, what Mexico is. That is not the same country as the US. It's not an extension of the US. It's not the same health system. It is not the same. They don't care about the same things. But we are neighbors, and we have interrelationships that are impossible to separate. And infectious diseases don't know anything about if you're on the Mexican side or the US side. So it made my job much easier because I can always start with that disclaimer. I'm not there as a Mexican. I'm not there as a US American citizen. I was there as an infectious disease public health specialist, and if I focused on that, people were welcoming and understood my mission.
Disease does not respect borders, and I think that's what we learned from COVID.
That's a very interesting story to learn. Yeah. Thank you so much for sharing your inspiring story and your passion for public health. This is a great experience for us to hear your story. Any more questions from your side, Robin?
No, I think a couple comments were just thanks for sharing your story. I think one question was if you have to choose between doing an MD MPH versus an MPH only, what would be the difference? And I think some people want to know about that.
An MPH versus what?
An MD MPH.
Oh, I say if you have the time, and some programs already begin as MD MPH. I had students at the CDC that I had one student I remember from Yale that was an MD MPH student. If you already know you like public health, and maybe if the MD MPH program is a year longer, or I don't, I would say do it. If you're going to be into public health, why not? Why do MD first and then MPH? It's helpful. I mean, MPH and epidemiology and biostatistics, even though a lot of physicians here, I'm going to say this humbly, but a lot of physicians think that they can do any other job just because they're physicians. You know, I always think we need to work in a multidisciplinary team. I'm not a biostatistician. I'm not a laboratorian that can produce a new diagnostic test for tuberculosis. I'm not somebody who, but I know a lot about those things because I use them. But I don't specialize on those things because you can only specialize on a few things to be good at them. MPH is a specialty, is your specialty in public health. You get epidemiology and statistics classes that you need that are different than just being a physician that likes math and things. I don't know. Don't be that. Do not be the type of physician that just by being a physician thinks they can do everything. Be humble. Learn. You can always learn more. And if you have time, MD, MPH, MD, PhD, if you like that track, if you're going to be a scientist, a researcher, an epidemiologist, it comes your way. Choose it. You will not regret it. It will give you different and new tools that you can apply when you graduate and go out into the work field.
Awesome. I don't think does anybody have any other questions?
I think we're all good.
Okay. All right. So yeah, so if you're interested in public health and you live in California, you have some people that are not in California, but there's the CDPH internships that you should definitely apply to. And yeah, and they're all local, so you don't have to move, or you could do it while in school. So I guess making a pitch for that. Well, thank you again for joining us, Dr. Villarino, and hopefully join us again. And thank you for giving us your Friday evening.
The beginning of my Friday evening, I am now going to go listen to a friend of mine who is a singer at a salsa, from a salsa band. So
Awesome.
Really
always
relax.
be proud of where you come. Always do your best. You can all do everything that's in front of you. It's a wonderful career that you have chosen to go down to, and I'm very happy that you are our future public health workforce and medical workforce. Thank you.
Thank you.
Thank you.